And I'm the first speaker. السلام عليكم. أنا أصلي سوري، وكنت عم بحكي مع الأخوة هون إنه أهلي راحوا على مصر بعد الحرب وبعد إجوا على السعودية. فالبلدين يعني نشكركم فضلكم، وبنحب المصريين والسعوديين. وطبعا وقفة سمو ولي العهد مع السوريين يعني ما بتنتسى. أنا أول مرة بالرياض وممنون. طيب, let's switch to English because I cannot speak medicine in Arabic. So this is the title I was given: Selecting Therapy in MASH, Matching Drug to Phenotype. So it's not exactly directed toward the update from the ASLD, but I will park on each indication. I'll tell you what we did or we present in the ASLD. Always there's a exciting and cutting edge at the ASLD. And I usually, like the big sponsors, they always want to get their abstracts in the ASLD and show the best science. So it was like a remarkable year for MASH. You remember 6-7 years ago, it was depressing. We didn't have treatments, trials were failing, but 2 years ago, we had the first drug approved therapy in the US. Now we have the second, so I'm going to talk about those in the subsequent slides. So those are my disclosures. So I'm just going to set the stage when we read the trials, and I'm sure all of you know this, but the disease progressed from MASL, used to be called NAFL, and this is just simple steatosis that progressed to steatohepatitis and eventually get fibrosis and cirrhosis. So the MASH and F2 and F3 is the area that we have been focused on therapeutically. That doesn't mean we ignore the stages earlier, because we do lifestyle intervention, we do lifestyle exercise, and we still treat the patients. However, the cost effectiveness and when the patient will start getting in trouble start at what we call at-risk MASH or MASH in F2 and F3. And eventually, if you get to cirrhosis, that's a big problem. And all of you, I don't have to explain, if you decompensate, it's not the best outcome for the patient. To read MASH clinical trials, you do have phase 2 trials, you do have phase 3 trials. Phase 2 trials are usually proof of concept. You put the patient, you do MRI, whatever the trial, you look at the MR fat fraction, you look at the ALT, and if the fat and inflammatory markers and fibrosis marker decrease, you move to phase 3. Phase 3 is still so far biopsy driven. So usually people do biopsy before and after, and what you need to show is improvement in histology. This is the score that people use, the activity score, and is a composite of steatosis, inflammation, and ballooning. And that's what I call it grading. So you need to score 4 and higher. It's 0 to 8, 4 and higher to get in the trial. So if you biopsy Dr. Noureddin, I have to have 4 and higher, let's say 6. So the outcome is you look at this 6 or the fibrosis stage 2 to 3, and there are cirrhotic trials. So if let's say I'm 6 and F2, if I go to the trial, that 6 either needs to go down to 0 or the F2 needs to go down to F1 or F3 need to go to F2. So if you hit this improvement in steatohepatitis or improvement in the fibrosis, the drug will get approved. Again, we focus on now what's called at-risk MASH or MASH in F2 and F3, significant advanced fibrosis, and the cirrhotics is a separate beast. And as you know, the goal of MASH therapy is holistic. You need to focus on the liver. And in addition, these patients have multiple other features of metabolic syndrome, such as type 2 diabetes, hypertension, dyslipidemia. And the goal is to improve liver outcomes as well as to improve their well-being and survival. So cardiac outcomes are really important in this disease, which is the leading cause of mortality in this disease overall, followed by liver mortality, especially when you get to F3 and F4. So I just explained the MASH resolution. Those are the primary endpoint for our clinical trials, and we're going to go through the clinical trials one by one, or fibrosis improvement. If you hit one of those in histology, the drug will get approved. So fortunately, we have 2 drugs approved. I don't think resmetirom is here in the Saudi yet, right? You guys have semaglutide, which is a weight loss medication, as well as type 2 diabetes medication, and it got approved also for the indication of MASH, and I will show you the trials. And I will point to the abstracts that were presented in the ASLD after these publications, especially in this last year. So let's talk about THR beta receptors. Actually, when I was in medical school, I did not know there are THR receptors within the liver. And then we learned over time there are receptors within the liver. So the initial fear was the alpha receptors because they are in the heart and the bone. So when the sponsor tried to do THR beta research, people were quite concerned about the heart, the bone. It turned out that THR beta receptors are selective to the liver. And what it does, it decreases de novo lipogenesis and pushes the fat within the liver to the mitochondria, increase beta fatty oxidation. And the results of that is steatosis, inflammation, and eventually fibrosis decrease within the liver. We actually did not know that, the hepatologists. It started from endocrinology, where they tried to do that research on dyslipidemia, and they started noticing the fat in the liver decrease, and they were like, okay, let's chase the liver with that. So this is a trial that we have conducted, led by our friend, Dr. Stephen Harrison, the belated Dr. Stephen Harrison, published in the New England Journal in 2024. What we did in this trial, we randomized the patient to placebo versus resmetirom 100 milligrams versus resmetirom 80 milligram. The entry criteria, I told you what it is. You need NAS and 4 and higher, steatohepatitis, and fibrosis, F2 and F3. There were some F1s in that trial. So 3 arms, let's look what happened this trial. On the left, you will see the primary endpoints, 2 of them. So the trial did hit the primary endpoint, the NASH resolution of a delta of 20%. In the middle, it did hit fibrosis improvement of 12% over 1 year duration. You will see now the trials vary in duration, so keep that in mind. There were also the effect on the lipid panel with improvement in the lipid panel. Side effects of these drugs were diarrhea and nausea, usually in the first couple of weeks, and then subside over time. And the drug has been prescribed in the US, and it's more than 30,000 patients now are on it. Before I go to the GLP-1, the abstracts that were presented this year on resmetirom were multiple. There are multiple trials other than this trial. One of the trials has been on open label on cirrhotics. And what we showed in the ASLD, that we showed that the transient elastography FibroScan improve on those with cirrhotics, pointing maybe when we finish the cirrhotic trial that is still ongoing, the phase 3, it's probably gonna decrease fibrosis and portal hypertension. We still cannot make conclusions. We should wait for that trial. Let's move to the GLP-1. Now everyone should have a GLP-1, right? It's very common, very popular. The type 2 diabetes now guidelines are switching to have this as a first line. So let me tell you about the GLP-1s. There are multiple. Semaglutide, that is very well known by everyone, is a GLP-1, and it's a GLP-1 alone. And the thought is it doesn't have effect in the liver, rather systemic therapy. And that's why other receptors been added to the liver, especially GLP-1 glucagon. One of the example is survodutide listed here. There are others, pemvidutide just entering the phase 3, and I will show you that. Tirzepatide is a GIP. It's approved for weight loss, already out there, and I'll show you some of these studies. Given the interest in GLP-1, I will point the abstracts. So the semaglutide has been approved in the US for MASH. This is the phase 3 trial that led to it. It's the first part is a histology part where we did, or biopsy was done before and after, and let's see the results. On the left, you see the NASH resolution that was statistically significant. On the right, you see fibrosis improvement that was also statistically significant. The side effects are GI side effects. I don't need to explain it to you. And what I presented at the ASLD this year, it showed that semaglutide can have a weight-independent effect presented by Professor Newsom on the liver, which was interesting. ASLD guidelines put guidance out there for the treatment of semaglutide and resmetirom. So please go and read it. And basically, we do not use liver biopsy in the US. We use transient elastography between 8 and 15, and those are the patients that they get treated overall. So I was given the title Matching the Drug to Phenotype. So let's read some cases. Case 1, 56-year-old patient with history of type 2 diabetes for 20 years who was been on GLP-1 for 5 years, BMIs that A1C is controlled, and FibroScan pointing toward F3 with steatosis. Those are the options, and we chose resmetirom this patient, given he does not need additional control for type 2 diabetes. Let's look at case 2. 53 years old man with a history of hypertension, sleep apnea, and obesity. BMI is 47, present for hepatosplenomegaly. The cap on the FibroScan 371, the stiffness is 8.6. Which one would you use? I'll keep moving for the sake of time. Here we chose semaglutide given the BMI on this patient and the need for weight loss on this patient. Another case, 61 years old Asian American woman, history of dyslipidemia, BMI of 22, so low weight, elevated ALT and AST, and transient elastography. So this is lean MASH, steatosis, and potential fibrosis. And on this patient, we chose resmetirom because she does not need a GLP-1. Let's look at case 4, 53-year-old man, history of hypertension, type 2 diabetes, uncontrolled, 8.6, BMI is on the high side, hepatosplenomegaly, quite a bit of stiffness, 13.6, almost at the edge of cirrhosis if you use the sensitive number, high cap. What would you treat this patient with? I can argue maybe you want to use both of them to try to reverse the disease as much as they can. It's not recommended yet to use both, but we have already started people on, for instance, resmetirom, and then a few months later we'll add semaglutide to add the metabolic effect to these patients. So do we need an additional drug approval to resmetirom and semaglutide? The answer is absolutely yes. There are many pros and cons of these medications. We need more efficacy. We need resmetirom does not lead to weight loss or A1C control. Semaglutide is systemic effect, not liver centric. So we need either combination or further medications. I will finish the talk in the next few minutes, the future treatments. So buckle up because there's so much, and I'm not presenting everything. I'm just presenting the phase 3 trials or those that they're going to enter phase 3s. So oral agents, we have lanifibranor is being now conducted, the research, and we expect the phase 3 trial results next year or the year after. Injectables, there are so many. Efruxifermin, begozafermin are FGF21s. They are very attractive drugs. Survodutide is a GLP-1 glucagon, and tirzepatide and retatrutide from the same sponsors. They are GLP-1, and retatrutide is actually GLP-1, GIP, and glucagon. Triple G. Sounds like gangster, right? So lanifibranor. Lanifibranor is an oral medication. In a New England Journal paper in phase 2, it did hit NASH resolution on the top. It did hit fibrosis improvement in the second line. And when we looked at the patients that they had the same thing, both NASH resolution, fibrosis improvement, it also did hit that. Moving on to the FGF21, which is they are very, very attractive. So there are multiple in stage 3 that are targeting F2 and F3, and they're even targeting cirrhosis. Let me start with the efruxifermin. The Harmony study from efruxifermin is FGF21. FGF21 play a role in glucose and lipid metabolism. In this trial, we actually did serial biopsy, baseline week 24 and week 96. And what you see here, the 75% compared to 25% placebo is the high fibrosis improvement that we have seen in any MASH trial. It's also the longest duration we have seen. That was also statistically significant in intention to treat. I don't present the cirrhotics here, but there was another trial called the Symmetry trial we published in the New England Journal, which showed for the first time in MASH cirrhotic patients, fibrosis was reversible, or it decreased by one stage. In this most recent AASLD, we looked at those cirrhotics that they had portal hypertension, and we showed decrease in the VCTE reading and the stiffness, suggesting even those with portal hypertension possibly can be treated. Moving on to metformin, another FGF21. This is MASH F2, F3 trial. It did also hit NASH resolution on the left and fibrosis improvement on the right. A third one just came in the Lancet and now started phase 3, a third FGF21. Now this is going also to phase 3 that was started. So 3 FGF21s. This is a 6-month trial with once monthly injection. That means only 6 doses led to MASH resolution here on the left and fibrosis improvement in the middle. So this is very attractive. Moving on to the incretins, tirzepatide in a phase 2 did hit NASH resolution and fibrosis improvement. Now it's going to phase 3 trial. Survodutide, and I think there's a program later on, also in a MASH in F2 and F3 study. It did hit both NASH resolution on the left and fibrosis improvement on the right. And the last one, GLP-1 glucagon, both survodutide and pemvidutide at GLP-1 glucagon, it did hit NASH resolution. This study was shorter duration than other GLP-1s. It did not hit fibrosis improvement. So we'll see what happens in phase 3, but the placebo rate was quite high here. This is actually the last slide. Triple G, retatrutide, is also entering to the phase 3. We don't have histology studies, but in a secondary analysis from obesity study, 80+% of the population resolved their fat in MRI. So ladies and gentlemen, we have MASH therapies that are finally approved. We have 2 of them. We don't need to use biopsy. We use non-invasive testing to prescribe them. So despite the approval, we have a very rich pipeline for MASH as well as the obesity. I didn't present cirrhosis, but the cirrhosis field also looks really bright. And congratulations to our patients who are in a good shape. Thank you very much.